So welcome to New Ways to Evolve, Change, and Grow. I'm Brian Harden, and today's guest is Dr. Ford Brewer, who's an incredible doctor that came from Johns Hopkins University, and he spends his life now educating people on the prevention of heart disease, heart attacks, stroke, and dementia. And he's got an incredible website called PrevMed, and he also is on YouTube at Dr. Ford Brewer. So here he is. Dr. Brewer, welcome.
It's interesting, Brian. I just did one of my my daily presentations was on this very topic. If you could let me present for just a second, I'll show you a little bit about it. Basically, what we did was we started talking about we're eyeball deep in the age of COVID-19 right now. New Orleans has been an epicenter in the U.S. U.S. is the epicenter now. New Orleans has been an epicenter as well as New York. Looks like it's heading to L.A., Chicago, Miami, some of the other large cities. The folks in New York and New Orleans are both. We showed a couple of clips. One clip from Fox News and another clip from a local news network where the docs and the public health officials were just amazed at the Fox News clip. You may have seen it. The doc was saying 23 of the 24 patients that he was dealing with in New York all had either full-blown diabetes or prediabetes. And these, again, are COVID-19 patients.
And Dr. Smith, I know in your patients today and yesterday, this week, you've seen an interesting and I guess disturbing trend of underlying conditions for those COVID patients. What are those?
I don't know if it's disturbing. It's a revelation, revealing. We're seeing a lot more diabetes than we've ever seen with any respiratory viral infection. I just did the calculation. We have 23 proven COVID patients. 13 are known diabetics. The other 9 are pre-diabetic. So only 1 out of 23 hospitalized COVID patients that we're taking care of, proven ones, is not diabetic or pre-diabetic. In the severe form, we had 15 patients with severe COVID disease in the ICU on the vet. 10 of those patients had diabetes, 4 had pre-diabetes.
Wow.
The only one who didn't was a 94-year-old man. We don't know if he had either. The testing wasn't done, and we still don't even have his COVID test back, so we're not even sure he fits that category. So the frequency of diabetes and pre-diabetes and high sugar levels when they present is enormous and something I've never seen associated with any viral infection.
Wow.
It's not really describing any of the literature I've seen so far, and I've been asking colleagues about it. For instance, influenza, while if people with diabetes should get the flu vaccine, it's not one of the main groups the CDC even recommends.
Okay, so this is Dr. Smith, this is one of the things we're going to learn a lot more about as this data keeps coming in.
The folks at the local news station in New Orleans were saying, the vast majority of these people are diabetic. That appears to be by far the biggest risk factor. So we talked a little bit about that in this presentation today. First, talking about the connection between diabetes and COVID risk, and then the connection between prediabetes, heart attack, and stroke. So again, we started off talking about the 2 big epicenters coming out of the blocks for the U.S. One of the big, it shouldn't be a surprise, but it is. One of the big surprises that people are walking out with is prediabetes is a major risk factor here. Now, so what I did next was basically take some of my recurring slides. As you know, Brian, from listening to my channel and doing some work internally with your own family, I continue to beat that drum about diabetes, and even more commonly, on a population basis, prediabetes as a major risk factor for these debilitating diseases. So if you can see this, are you able to see my slides right now?
Yes, I am.
Okay. So when you look at this slide, all I did was took one of the slides where I'm showing some heart disease by county in the US. This is a CDC slide on the left. Stroke death rates by county on the right. And then just took the current Hopkins COVID-19 map. Now, the first thing you see is fairly simple, fairly obvious, and it's not so much an issue of risk as it may be just an issue of population centers. Obviously, the eastern half of the United States and the western coast, the West Coast, are more heavily populated than the mountain area. We get all that. But as you dig a little bit deeper, there's some maybe subtle differences. For example, look at New York State. With New York State, you have a significant risk of heart attack on the left, not quite so much risk on stroke on the right. And again, New York is a major epicenter for COVID. Now, what might be causing that? Well, I will tell you, there's a significant difference in terms of what we call telestroke. It's the ability to treat stroke through telemedicine. So, and that's happening more in limited areas in the country. That may be the issue that we're seeing, those subtle differences in New York State. It may just be an issue that we're managing high blood pressure better in New York State than we're managing some of the other prediabetes related issues, because prediabetes alone is the major risk factor for heart attack. Although it's a major risk factor for stroke as well, high blood pressure is also a big deal. Now, again, you look at COVID, and again, as we're finding out, diabetes, prediabetes, major risk factor there. Another subtle but interesting difference between heart attack and stroke is the California versus Nevada. As you see here, California is much more of a much higher relative stroke rates compared to Nevada, whereas it's the opposite way around, much higher heart attack rates in Nevada, and comparatively less in California. So again, we've got some interesting differences there. But one of the key things that you see, that I see, especially given my own culture, as you probably haven't noticed, I've got a very thick South Carolina accent, southeastern U.S. accent.
It's fantastic. I love it.
And obviously I'm being facetious. It was only after almost, 7 years in Baltimore and another 7 years in New York, it was only then that people began to stop asking me, "Where are you from, boy?" And all it took was one day back in Nashville, Tennessee, and almost all of that accent came back. Anyhow, so much about accents, but I'm from the Southeast, and as you see, no matter which of these diseases you're talking about, the number one killer with heart attack, the number one disabler with stroke, or now with upcoming COVID, big issues with diabetes. And as I mentioned before, there's a big question about prediabetes. What we have done in terms of a culture, including our doctors and the CDC, our medical leadership, we focused on full-blown diabetes. And you see the CDC is doing that now. They're saying with COVID, it's diabetes with complications. But let's go back and ask a bigger question. From a population perspective, how about prediabetes? Are we not at risk if we just have, quote, a touch of sugar? If our doctor has seen a hemoglobin A1C of 5.5 and it's not a full-blown 6 or 7 yet? Well, let's go back and see what the CDC's been saying for a while. As conservative as they are, they say, look, prediabetes is a significant risk factor. It's a risk factor for type 2 diabetes, heart attack, stroke. And again, as you and I mentioned earlier, have you ever heard of type 3 diabetes? In other words, Alzheimer's, cognition problems, dementia. So yes, these are all major risk factors, and prediabetes is a risk factor for these. Now, how about eye disease? So if I don't
could
have
I ask a
full-blown-
question as part of that? Could I, before we go there? Because there's plaque in those blood vessels for the stroke and for the heart attack, it probably also is in the brain too. Is that correct? And how is the plaque and the sugar tied together? Is there any relationship?
Funny you should ask. Number one, let me go back and say this. Well, you're right. This is only a problem for tissues that are dependent on arteries, and therefore plaque in the arteries. We'll talk about plaque in just a second. But which tissues are dependent on arteries? Well, your brain. This is the number one cause of stroke and dementia. Your heart, number one cause of heart attack and heart failure. Kidneys, number one cause of kidney failure. Eyes, number one cause of blindness. Your gums, your mouth, oral disease, erectile dysfunction, peripheral disease, etc. And you, I think you nailed it, Brian, when you said plaque. That's what's going on here. I mean, this is a diagram of an artery that's going through this progression of plaque formation. This starts out as a, quote, normal artery, end quote, and then you get more and more and more plaque laid down. Pretty soon, once you get to this level, your immune system starts attacking that plaque and saying, look, this is not supposed to be here. I'm going to do what I do anytime I find something that's not supposed to be there. I'm going to send in immune cells, antibodies. They're going to release enzymes and attack this stuff. They'll liquefy it, and I'll get rid of it. Well, all of that works until you get to this point to where that liquefied, or what we call hot plaque, will go back into the bloodstream. And if it breaks through that thin layer, that intimate layer, and goes back into the bloodstream, the chemicals in here, the same chemicals that cause that inflammation, can cause a clot. Now, all of that sounds theoretically very nice when you're talking about theory, but is it real? Well, here you go. I mean, you look at this, these are actual pictures of arteries of patients that have recently died of heart attack. In this first one, you see, this is the media layer. That's that muscle layer right there. There's a tiny little thin intima layer here. And as you look at that, that's the intima layer right here. And when this intima layer gets irritated or inflamed, LDL, cholesterol, quote, the bad cholesterol, seeps through that intima layer, but it won't seep through the muscle layer, the media layer, so it gets stuck. That is exactly what's causing this buildup of plaque. Most people think that plaque clogs up the arteries like hair clogs up a drain. That's not really the mechanism. What happens is you get inflammation of this intima layer, and then LDL or cholesterol seeps through, but it gets stuck. So when you look at this, that's all a waxy substance. It's LDL. And that's why we went down this bunny hole for 60, 70 years. A lot of people want to blame the cholesterol misperception on Ansel Keys. Well, Ansel Keys had a strong personality. He had a lot of influence. But here was the thing. He didn't create this misperception. He just pushed it. This is mostly LDL, mostly cholesterol. So people logically thought, well, if all of this plaque is cholesterol, it's got to be cholesterol in your blood. What they didn't realize was it was this inflammation process or this burning of that intima layer. So when you consider that's what's going on, then the next question is this. Well, what actually causes the heart attack itself or the stroke itself? And we'll talk about that cognitive decline in just a second. Here's what happens. The immune system attacks that plaque, recognizes it as foreign, sends in enzymes. These enzymes create, they liquefy this stuff. And that's why you get this funny looking space here. Do you see what I'm talking about?
Oh, yes. Yeah.
So then, once that liquid plaque is there, you've got a significant risk. All it has to do is break back through into the liquid bloodstream. And if it does, it can cause a clot. If the clot's big enough and goes to the heart, it causes a heart attack. If it's big enough and it causes a clot, and if the clot's big enough and goes to the brain, it causes a stroke. Here's another version of this. Again, another real version. This is the muscle layer or the media. This is that intima layer right there that you see here. And here's a couple of cracks. Now this black thing here it's not that hot plaque. This black thing is the clot. And as you see, once you had that clot formation, it went back into this area that used to be hot plaque, that little pocket right there. The biggest part of the clot broke off, went to the heart, killed the patient. Now, a minute ago, what we said was, well, what about heart failure? And what about progressive decline of heart function or even progressive decline of brain function with senility, progressive decline of visual function, erectile function, kidneys, etc. Well, if you think about this is a very large macro, MACR, or visible problem going on. If you have this metabolism going on, think about it. This can be going on microscopically in thousands of areas within your blood vessels all at the same time. So in other words, you can be throwing microscopic clots hour after hour, day after day, week after week, month after month. And if you take a microscope and begin to look at the tissue, microscopically, it can start looking like Swiss cheese. I mean, you just get major disruption of the tissue itself. And again, those are some of the reasons why we get what we consider aging of the brain, what we consider dementia, what we consider loss of function of heart muscle, stuff like that.
So I have an odd three-part additional question, which I don't know if any of this is relevant. So they changed our sugar from the old, from fruit to then white powdered sugar, and then now they have high fructose corn syrup. And so all that's just a chemical soup. And so those types of sugar, I wonder how they respond. Number two is calcium. It's been a fad for 20 or 30 years, throwing calcium at everyone. But a lot of people have forgotten to add vitamin D3 and K2, which helps to pull that out of, and put it in the bones, out of the system. And the third part of that is alkalinity. So do any of those have any relevance to this? And if so, please help us.
So just a couple of comments. As you mentioned, there's some significant distinctions between some of the key sugars, glucose, fructose, and sucrose. And unless I've screwed up my chemistry, I think glucose is a fructose and sucrose molecule joined together. We know that fructose, and I'm not the expert in this area. If you go to somebody like Robert Lustig, the medical director for the Obesity Center at UC San Francisco. And he's written a bunch of books and done a bunch of videos on this. Major focus on fructose, and shows some of the significant differences in the way that fructose, or the sugar associated with fruit juices and corn, are in many ways more dangerous than regular glucose. I'll just mention that, then I'll go on to a couple of other comments. A lot of people think, okay, well, if I get cane sugar, which these days I think is more sourceable through Mexico than most of the American sources. It was very sourceable in the Louisiana area and Hawaii for a while in the U.S., but much less so now. That was far safer. In many ways, it probably was. I would say, though, as you might have guessed from listening to me, a major part of my practice, my function, my role is to point out unrecognized diabetes. And yes, as endocrinologists like Robert Lustig and his counterpart David Ludwig at Harvard would say, yes, carbohydrates in our diet matter. They matter a lot. And I will also tell you that when people first begin to open their eyes to some of this dietary problem that you brought up, their first reaction is, oh, my doc said I've got a touch of sugar. So what I'll do then is I'll have one teaspoon of sugar in my coffee in the morning instead of 2. Well, and then meanwhile, they have oatmeal and or cereal and or orange juice for breakfast, and pasta for lunch, and rice and pasta and or pasta for or potatoes for dinner. And it's
you add bread to that too.
What they're not getting. Oh yeah, and all of these. Pardon me, you're exactly right. Even more so than any of them, they're having a sandwich for lunch or dinner, and or toast with or bread. And so, yeah, they don't get the fact that they're getting far more carbs on a daily basis and a long-acting basis from grains than they are from sugars. So, again, what we need to do. There's another author I would alert your viewers to, and that is Sue Ruhl, or Jenny Ruhl, JennyRuhl. She's got a website and a book titled Blood Sugar 101. It's an award-winning. Both of them are award-winning, and both of them are helping folks begin to understand this whole problem of just how prevalent diabetes and prediabetes is. To get back to prevalence or portion of people that have this, even the CDC used to say, well, a third of the adult population has it, especially 60 years old and older. And that was 80 million out of the 240 million adults. But then they began to realize that that number may be low. And where did that come from? Again, other government associated groups like UCLA 2 years ago published a very good survey showing that it wasn't a third of adults in California, it was a half. And it wasn't starting at age 60, it was starting at age 30.
Wow,
so
30.
Much more common than we thought. If you start thinking about, okay, anybody over 30, over a 50% probability of having this problem, burning their arteries, it's like, look to the left, look to the right. Which of you doesn't have it, really, rather than who's got it?
So how is this all tied to lifestyle? Because obviously we've been promoted to no longer cook anymore, to just do convenience fast food, and everybody's on a rush. So then we buy chemically made, man-made stuff and things that aren't vibrating, with nature, and we don't put our own joy and love into the food and making it. And so, of course, we end up with chemically induced, flavored, more flavor and less anything that's vibrating. So how's that lifestyle all work with this?
The New England Journal did an article. They compared, as a simple head-to-head comparison, a very simple, low-level, not very aggressive health coaching program versus a drug. Well, the most commonly used drug, metformin, for prediabetes. And these lifestyle programs are typically, doctors don't focus on them because they feel like you can't change people's behavior en masse. I mean, we're talking about overall average losing less than 5 pounds, less than 2 hours a week of very moderate to mild exercise. But here's what happened. That was 3 times more effective than normal doses of a prescription drug, metformin. So here's the bottom line. Medications can help. Supplements can help. But neither one of them is going to make an impact compared to lifestyle. What we've also seen even more recently is even stents and bypass surgery, opening up your chest and doing surgery. These things really don't do what 90% of them are meant to do, and that is prevent heart attack. So again, you cannot supplement your way out of a lifestyle problem. You cannot medicate your way out of a lifestyle problem. You can't do surgery or procedures and get out of a lifestyle problem. You got to go back to lifestyle. Now, what's the most important thing in terms of lifestyle in diabetes and prediabetes control? Diet, and then diet. And that's frustrating because, a lot of people say, well, exercise is important. It's very important, but I mean, you can look at the internet and look it up, Google it. Google eating versus running on a treadmill. And people have made videos where you've got one guy who's running as fast as he can, hard uphill, which is hard to do. And the guy next to him is sitting down, drinking beer and eating a pizza. And they're doing calorie meters for both of them. And the guy that's eating, the calorie meter's going around like this, whereas, the guy that's running as hard as he can is just barely touching it. So yes, it's important to exercise because it has more of a lasting impact than just what you see on that calorimeter. But nothing compares to diet. There's a major problem, and I've hesitated many times to get involved in that debate. You've got the plant-based dieters versus the keto dieters.
My opinion of diets is a diet is something you temporarily have and you attach yourself to, and it's really not establishing habits. And so if you're on a diet, rethink what your habits are and retrain yourself to make it your lifestyle instead of just a fad you're going through for a month or two, right?
Excellent redirection, Brian. And actually, I would take you back to another book that's short. It's probably at least 5 years old now. It's also by Jenny Rule. And it's called Diet 101. She covered some of the, it's interesting how little good research was done on diets. When, what's his name? The Scarsdale diet doc, when he died, he left some money that went into several really good programs and surveys, randomized clinical trials. And one thing that it showed was that, keto probably is safe, But the biggest thing that it showed, more than anything else, gets back to exactly what you just said, Brian. The best diet's not a diet. The best diet is a permanent change in lifestyle. If you can't keep it up for 6 months or more, don't even go there. Mm-hmm. So it's got to be something that you're comfortable with, that you can develop an ongoing lifestyle change. Otherwise, it's just not worthwhile.
I need to tell you a little thing, which is for me, I was diagnosed, I'm 56 right now, and I was diagnosed with irritable bowel syndrome about 20 years ago or 25 years ago. And, after $5,000 worth of testing, they said, you have irritable bowel syndrome. Okay, what's that? Well, your bowels are irritated. Okay, and so how do I fix it? Well, it's a syndrome. Well, we don't know how to fix it. Duh. How do you fix it? You change what you're putting in. If you had bad gas in your car and put bad gas in your car and it caused the car a problem, would you continue doing it? No, of course not. So I, of course, changed my diet, but I was living in Nashville, Tennessee at the time, and you know what that's like. Everything's fried, smothered, slathered, whatever, and all the vegetables are pork, right? Add a little ham to your vegetables, and that's what you got, right? There's your vegetable. And so everything was fat and delicious, but it wasn't necessarily healthy for me. And then everything was also genetically modified at the time. It started to be, in around 1995, all the GMOs came in and the pesticides. Well, I mostly got rid of the horrible things with the irritable bowel syndrome, but I ran around with it for 15 or so years, and it wasn't until I was finally myself sick and tired of being sick and tired that I stepped up and made a change. And I watched a film called Fat, Sick, and Nearly Dead, if you've ever seen that. He recommends to do a fast and to do some juicing. And so I followed it. 21 days later, all of my symptoms were gone. I had, like you were saying, pre-diabetes. I had carpal tunnel. I had all sorts of joint issues, back pain, couldn't sleep. Everything was gone in 21 days, and never has it returned because I went organic. And so it was the pesticides that were messing me up and all the food additives, and I started getting real food as opposed to the fake food. And, the fake food's delicious and easy. But once I changed all that, then I didn't need a multivitamin. The vitamin was my food. And have you had similar changes in your life?
For me, it was mostly a carb-related issue. Mm-hmm. Despite running marathons and even an ultra marathon, I was never able to get my waist size below 30. 33, 34 pants size. And it wasn't until I was in my early 60s that I finally got my pants size down to 32. I always had this, like these saddlebags. And again, it has to do with constant carbs. So yes, there's a whole lot. It's like the old IT thing, the programmer thing: garbage in, garbage out. And I think there's a lot more recognition that diet is important. What gets kind of foggy and murky after that is which diet is best. And I think what you and I have just demonstrated with a series of 2 is that it really depends on what the underlying problem is.
Yeah, and all of that caused inflammation in me. Just the toxins and the extra chemicals and whatever else were causing the inflammation. But I, of course, was the pizza and pasta guy and bread and just ate normal, but it wasn't making me feel good. And so now everything I put in my mouth, I analyze a few hours later, does it make me feel good or bad? And if it's making me feel bad and stealing my energy, I need to rethink what I'm putting in. And it's that simple. It's not complex. Yeah.
No. And I would say from my own perspective and a lot of my experience with patients is that you're focused on organic. A couple of the examples you brought up coming out of the blocks, very, very heavy carb related stuff as well. Pizza and pasta.
Yeah. I find when I eat things that don't agree with me, my joints hurt the next day. And so if my joints are hurting, my stomach's inflamed. The inflammation is not only in the joints, but it's in my spine, it's also in my digestive system, and then eventually the arteries and so on get inflamed. Inflammation's not in just one little area, so it's everywhere. Yeah.
You know, interesting comment about diets and lifestyle, and your comment about pizza and pasta. Have you ever heard of haptoglobin?
Haptoglobin, no, could you explain?
So, our body drives on hemoglobin, right?
Yes.
And the fact that there's a difference biochemically, and pardon me if this is too geeky, but we use oxygen to burn glucose and other things, right?
Yes.
So that makes a big difference. That's because of that we get like 36 energy units out of a sugar molecule compared to yeast, the yeast that we use to make alcohol, which only gets 6. Now, so every advantage also brings some disadvantage, right? Every solution creates a new set of problems. There's a thing called haptoglobin, and what it does is it actually cleans up broken, worn out hemoglobin. Because, hemoglobin, that's located in our red blood cells. And our red blood cells have they tend to exist for about 90 days and then they blow up. Then they spill hemoglobin all over the vessel. And hemoglobin's got that oxygen in it. Well, what does oxygen do? It oxidizes, or what's oxidation? It's rust or inflammation. So we've got this source of inflammation with the constant turnover and spillage of hemoglobin. Well, that's what haptoglobin's here for. Haptoglobin is there to pull that hemoglobin out. Well, there's a very common genetic variation. In fact, about half of us have a variation that really impacts our function for haptoglobin. In other words, a lot of us have hemoglobin just spilling out, causing oxidation on a regular basis. Now, why is that? Well, it seems to be something that tracks right along with sickle trait, the thalassemias, all things that have an impact. When you have these diseases, haptoglobin, thalassemia, sickle disease, your risks for some diseases, as in malaria, are much less. You're much more resistant to malaria. So everybody living in the tropic areas or everywhere where there's been malaria, there seems to have been genetic pressure to push that up. Well, that may help save you from some infectious diseases like malaria. On the other hand, though, it has a very inflammatory component, because if you're spilling oxygen and leaving it in your blood vessels, you just increase this inflammatory process that we talked about. Now, that sounds like a weird, unusual thing. Maybe interesting, but not that practical. Well, let's step back and think about it. The major thing that's killing people is heart attack. The major thing that's disabling people is stroke. By far, the major risk factor for those is diabetes and prediabetes. And guess what? If you have diabetics are 5 times more likely to have cardiovascular disease if they have this haptoglobin. They're 3 times more likely to have cardiovascular disease if they have just one allele. In other words, heterozygous. You familiar with heterozygous versus homozygous?
No, I'm not. No.
It's genetics. You know, if you got one haptoglobin 2 from your mom and one from your dad, then you're a hap 1-2.
Okay.
If you got haptoglobin 2-2, haptoglobin 2 from your mom, haptoglobin 2 from your dad, again, you're 5 times more likely to have cardiovascular disease. So it's actually.
Do you have an issue? I remember hearing a video that you spoke that you had something. Is this the issue that you had genetically?
No, I have 4q25, which is the atrial fib gene. I have that homozygous, and I have a significant dose of 9p21, which is the quote heart attack gene. We used to think it was the heart attack gene, and now we realize. Even before that, we thought it was a cancer gene. At the end of the day, what we have found out is it's a diabetic gene, prediabetes gene. And I've got a significant amount. I'm not alone. Again, over half the population has versions of that. So we've got significant genetic risk factors. The reason I wanted to come and mention this haptoglobin in and of itself was your mention about grains, pastas and pizza. The haptoglobin has been mapped out. They thought that Alessio Fasano, the guy that discovered it, was a nut when he mentioned it and described it to the rest of the world, because he came up with one of those nutty diseases that nutty doctors talk about and nutty patients that really don't have a lot of science behind what they're talking about.
Like shaky leg syndrome. It was one of those?
Yeah, yeah. And everybody, including myself, made fun of it, didn't believe it. This was called leaky gut syndrome.
Oh, yeah. Which that's the big deal, because when the food particles break the blood barrier there, it gets into the bloodstream, and then it clogs up the blood things, and there's your stroke, there's your heart attack, there's your brain issues too, because it's got to go somewhere. The small blood vessels in the brain definitely are a great place for it all to collect, you know.
Yep. So that's the thing. I wish I had, I can't find the right slide deck, but here's the punchline on all of this story, Brian. The precursor to hemoglobin is called zonulin, and the major thing that trips zonulin and these leaky gut processes off is a lectin called gluten and gliadins. So all of this story, you know, it was a big fad for a long time for people to talk about gluten-free diet. At the end of the day, there's some very significant, very hard science behind this whole gluten-free diet, the impact of and its impact on leaky gut. And in addition, along the way, a major story about heart attack and stroke with it as well.
Could I add to that? Again, for me, not only is the gluten an issue, but for me, the pesticides that they use on the genetically modified wheat became also an additive issue too, because in 1995-ish, that's when they started genetically modifying corn, wheat, and soy, which now have glyphosate on them. And so that chemical messed up my stomach in addition to the gluten. So yes, I see that as a piggybacker on top of the gluten. Does that make any sense?
It makes a lot of sense. I have to admit, that was one of the things that I was blind to, just given my own filters of science. As as you might have guessed, I did some postgraduate work in terms of genetics and worked with a genetics lab for many years. And I originally felt like, oh, this whole focus on organic and non-GMO is a red herring, because I really, it wasn't as common as people thought. There were only like 5 or 6 products that had those. The genetic modifications were not that big. And the reality is we have been genetically modifying things like grains for generations, for hundreds of years. We've just not been doing it by going into the genes themselves. But here's what I was missing when I was being such a skeptic. It's what you just brought up. A lot of the more recent genetic modifications make it possible for us to just dump glyphosate and other very nasty chemicals on our food. So, yeah, there may be a big impact, and as you're saying, I think you've got a good case and a good point. Very big impact from pesticides, which were made possible by the genetic modification. I think we might have frozen up. I'm
still getting video fine. I see your mouse moving, and I see your images all fine.
Oh, okay, good.
Yeah, I'm getting you great. So,
okay.
Does calcium in D3 and K2, is there anything to mention on that, or should we leave that one alone? And same thing with alkalinity. Is there any attributes to that have to do with the inflammation? And
I will tell you this: alkalinity may have an issue, but I'm not the guy to ask about it. Don't know that much about it, but I've done my own journey in terms of K2, and yes, I'd like to talk about that for just a second. My first, when you look at my channel, my first most popular video was a video where I shared my own experience reversing about 20 years worth of arterial plaque. My second most popular video was on K2. And it came out of the blocks a little bit skeptical, as I am with most things. And I couldn't understand why people were so interested in it. Until I finally decided to go ahead and read a book that really talked about, it sung praises for K2. The science for the book didn't appear to be that strong. And my original video on it, my original cut, went straight into randomized clinical trials. Well, here's the thing. If you look at the randomized clinical trials about K2, they're still not that strong. There's a thing called the Rotterdam study, and it was about as strong as you got, and it was not earth-shaking. So again, I came across originally as skeptical. Then I started reading some of the books. I can't remember her name. She's a doctor of nutrition. I think she's Canadian. It's got a French-Canadian name, and I can't remember it right now. It's hyphenated. But I read her book, and I got fairly worn out about hearing about grass-fed beef. So here I was, still skeptical. But then they mentioned something about a couple of enzymes, and I began to look those up, and I began to see a whole different perspective on this question. There's an enzyme called osteocalcin. There's also another one. It's called PDA. I'm blanking on the letters for the acronym, but both of these are enzymes which, once they're carboxylated, they do have a critical component. They have to do with adding calcium to the bone or taking calcium back out of the bone. So that's where you get this story about calcium, K2 moving calcium from the arteries where you don't want it to be to the bone. I think at the end of the day, they may actually have an impact, but it's not what most people think. As I got more and more interested in investigating the science behind that, it became really clear that osteocalcin, for sure, and maybe the other ones as well, are very much related to prediabetes. So I actually was even able to find a randomized clinical trial where they took relatively young men with significant prediabetes, gave them much higher levels of K2 than you usually see, and had a significant decrease in insulin resistance. So guess what? I started taking K2 in a big way. I supplement it, and then I also take a powdered natto.
Do you do D3 you know. With the K2 also?
I've taken D3 for a long time.
So both
long
together?
Before the K2 story.
But do they both work together in some way? Do you know?
Well, again, you go back and you know that D3's got a significant impact on calcium metabolism. That comes more from the kidney and the hormone. Actually, you can make a strong case that D3 itself is actually more of a hormone than a vitamin. It doesn't matter. So, I mean, who wins that debate? The bottom line is it does impact it. So because both of them have to do with calcium, I think that's the urban myth, the urban legend that they work together. Here's what I think. I think they both have independent impacts on prediabetes.
Could you tell us about the 3 courses that you have on your website that you help people with stroke, with the heart attack, and with the dementia, that you customized to help people and make it affordable for them to get great information?
Sure, and thanks for asking. I'll just go to my website real quick. We are, as you can tell, we never really put that much of an investment into the website. We are starting right now. It's always been what you'd call what the web developers would call a brochure website, meaning it's basically nothing but not that much, but a brochure. We are starting to develop some blogs, some other information, which is available now for free to folks. But you ask a very specific question, and again, this question has to do with courses that are available for, gosh, it was $29. The first, 30 to 50 were free just to get people to look at them and give us feedback, and they did. Then it was like 29. I think it's like 39 or 49 right now. And if that's a problem for you, start looking for and asking for a sale. We still have sales to try to get those out there for people who that kind of money is a big deal. So they really consist of the core curriculum for what we do in terms of helping people understand the major risks to their health. Now, most people don't really know or understand insulin resistance or prediabetes. Even when they hear the term nobody understands what insulin resistance is. So we put that one for maybe the second or third. Most people do understand plaque, though, cardiovascular plaque. They say, well, you know, my doc said I've got a little plaque. I need to get a stress test. Well, what we've done now is we've said, look, there are about 6 key ways of evaluating plaque. One is the stress test. And here's the big problem with a stress test. Look up, if you Google stress test, false positive, false negative, NIH, you'll see the snippet. You know what a Google snippet is, right?
Oh, of course, yeah.
So the snippet, the position 0 on the search engine results page, says, you know, there's what, 6 or 8 million stress tests being done each year, and it'll say 1.5 million of those are wrong. We know that. We just don't know which 1.5 million. So it gets you back to the old Dirty Harry movies. Well, you go get a stress test like your doc recommends. Are you feeling lucky? Because you're playing Russian roulette when you do that. 1 out of 5 is wrong, and everybody knows it. They just don't know which one. There ought to be a better way, since you're looking at the #1 cause of death and the #1 cause of disability. And it turns out there are better ways. For example, well, let me just go down that bad path of stress tests a little bit further. If you have a positive stress test, whether it's wrong, whether it's false, positive, or true, you're going to go to the cath lab next. They're going to stick a needle in your groin. They're going to thread a needle up into your heart, and then, or a tube up into your heart, shoot you full of dye and take an x-ray. They're going to find plaque almost always. Now, but they don't know whether that plaque's stable or not. And again, it's sort of like if you're a hammer, everything looks like a nail. If you see plaque and somebody's got symptoms or they've had a positive stress test, and you're going to see plaque, you're probably going to put a stent in. You know, just stenting is very, very common, and 90% of stents are put in to prevent heart attacks. New England Journal, Lancet, all the other big journals have published articles. Stents do not prevent heart attack. So you go back and you ask, well, wait a minute. Why are we doing stress tests, and why are they so often wrong? Well, a stress test is set up to be positive if you have 50% or more of a blockage to your flow, the flow in your arteries of your heart. Well, here's the thing. That is true. That's what happens. But 2/3, 69% of heart attacks occur in people who don't have as much as 50% blockage in the arteries of their heart. So yes, it's a good blunt instrument for finding something, but it misses the majority of heart attack and stroke risk. So how should you be doing this? Rather than the 15,000 people a day that are getting a stress test, you should probably be looking at some other tests. And clearly there are other tests. There's the calcium score, which people know about. You can watch the movie Widowmaker. Calcium scores way underused and a very, very good way to check out plaque. Another one is CIMT. CIMT has its own problems. It's you've got to be very careful about the quality and who does it. A third one, which is a big up-and-comer, is the CT angiogram. So pardon me for taking so long to describe it, but you asked. That's what the plaque course is all about. It helps people understand, what should I really be doing? What's my doctor recommending, and what should I know? Because we all know medicine is caveat emptor, buyer beware. You're going to get what you're going to get, and unfortunately, you need to be a much more informed purchaser. So once you start going down that path, you start thinking, well, what caused my plaque in the first place? Well, you start realizing that there's a thing called inflammation. You and I have already talked about it many times during this interview. So the reality is, inflammation of those arteries is what causes plaque to get laid down. So that very first course that we made is cardiovascular inflammation, and it goes into what is inflammation. As you may remember earlier in this interview, we talked about you can have plaque, but it's when you get inflamed plaque that you get the major risk for immediate heart attack or stroke. It's that hot liquid plaque that can spill back out and form a clot. So that's what that cardiovascular inflammation course is. It actually shows you the immune system function, how the immune system picks up on plaque, what causes that inflammation, how it releases enzymes, including pictures of photomicrographs where it's picking up the enzymes and the cells that are releasing enzymes to cause that inflammation. Now, as you continue to walk backwards, first starting with plaque, which most people recognize as a risk, to inflammation, and then the next question becomes, well, what causes inflammation? 4 out of 5 or 80% or more is caused by insulin resistance. And, that gets us back to the original topic we started talking about. Insulin resistance seems to be the thing that makes you susceptible to heart attack, to stroke, to COVID-19, not just you can get infected with SARS-CoV-2, the virus, but it's the people with insulin and maybe even insulin resistance or prediabetes that have major susceptibility to death from this infection. It's also insulin resistance, prediabetes. It's all.
Do you find that most people that have these issues have an inflamed gut? Have gut issues, stomach issues?
It's very, very common to see overlap. Gut inflammation, you and I spent a significant amount of time talking about it, and it sounds from talking with you that you've spent a significant number of years dealing with it on a personal basis. Mm-hmm. And if you go back and you look at the genetics that we talked about, over half of us have the prediabetes gene that I talked about, and over half of us have the haptoglobin, that gut-related gene that we talked about as well. So both of these are extremely common. Anyhow, so that's a walkthrough on the 3 basic courses. The insulin resistance course first talks about how common it is, and then why it's important to be looking for that. And then it ends up with, how can you find out for yourself if you have prediabetes or insulin resistance? Because I hate to say it, this is not a criticism of docs. I spent most of my life as a corporate medical director. So I've hired and managed docs my whole life. Docs are just like other people. They want to do the best they can. They want to help others. But we all have realistic constraints. And if you wait on your doctor to tell you you've got insulin resistance or prediabetes, you're making a fatal mistake that tens of and hundreds of millions of people are making on a daily basis.
So there
you go. Thank you again for asking about those courses.
Well, all 3 of these courses are critical for healing what's going on in the U.S. because these are some of the top leading causes of death, and all this together is related to dementia, and that significantly, is something that I'm also concerned with too. As we age, we lose our memory, and what causes it, and it's all right here, and we can fix it.
It is. It's interesting as you begin to go through this. We used to call all these things just part of aging. Well, your eyes get bad when you age. Well, you start to have a heart attack when you hit your 60s. Well, you start to lose sexual function. Your kidneys go bad. Your brain goes bad. Well, you know what? All of these things go back to, for the vast 80% of us, prediabetes, insulin resistance.
And what is the cause of all that prediabetes and insulin resistance is often, what are you eating? What are you putting in? What are your lifestyle choices?
It's a big.
Yeah.
It is a big deal. Lifestyle is again, the lifestyle choices are the key issue here. Mm-hmm. And you can't run from them.
No.
Genetics are important, but genetics loads the gun. It doesn't pull the trigger. Lifestyle pulls the trigger. Age is important. You know, you don't see a lot of diabetes in 15-year-olds. We're starting to see it with the obesity epidemic. Speaking of which, obesity is important. But you take those three big items, age, genetics, and obesity. There's only one of those that we can deal with, we can impact, and that is obesity. And obesity is the biggest of the lifestyle components. It, like the other lifestyle components, is very dependent on diet. There are many of us, like myself, who really weren't obese. I had a BMI of 22, 23 when I first started to develop insulin resistance, but I was getting into my late 50s. And so I had a couple of things going on. I had some significant genetics, some significant age, and I had a little bit of body fat. So there's still things you can do, even though you think, oh, I've just got a target on my forehead, a target on my chest. I can't change my genetics. I can't change. I thought so too. I thought I was the poster boy for lifestyle. After about 18 months of my first arterial age showing 73 years old, 73-year-old arteries when I was age 57.
And you were a runner too at the time, right?
Again,
were you a runner at the time?
Oh yeah, that was about the time I did an ultra marathon, and it's like, dang, and a BMI of about 20, 21 and a half, 22, 73-year-old arteries. I got my CIMT and expected to do a victory lap. And instead, I got slapped in the face with really bad arterial health. It didn't take a whole lot. I broke down and I started taking a statin. I lost about 8 more pounds and I cut the carbs. Now, which of those made a difference? It's hard to say. But over the next 18 months, I dropped down to a 52-year-old arterial health. 20 years with just some minimal changes.
So I know you've spoken about statins and that people demonize them. And so I wonder, because statins are known to also limit the cholesterol, and the cholesterol is part of the brain. And so I think some of that issue that they criticize statins for is that it thins out the fat in the brain, the cholesterol in the brain. Is there a balance between all that, or is there a type of statin that's less effective, or a type of, it's LDL and HDL? Is there any type of cholesterol that's actually good for your brain that you could take with statins? Is there any relationship to that? I don't know. Yeah.
It's a great question, and as you can imagine, that debate is as big as the diet and macronutrient debate. But here, you're exactly right. There's a balance issue here. First of all, I don't recommend, well, even before that, cholesterol is a major part of all of our cell membranes. You know, you talk about COVID-2 and the ACE2 inhibitor, the ACE2 receptor. That's how the virus gets in, and zinc being something that helps. It stops that RNA-dependent RNA polymerase that the coronavirus hijacks. Well, you can't get the zinc in there because it's going through that cell membrane of cholesterol. Well, the way you get the zinc in through that cell membrane is you use flavonols or quercetin, which is a flavanol, or chloroquine or hydroxychloroquine. All of those, look, if you take a look at the chemical structure, the molecular structure of quercetin, chloroquine, and hydroxychloroquine, all of them look very much like a cholesterol molecule. That's how they help zinc pass through that cell membrane. Again, cholesterol is a huge portion of our brain. So no, I don't think statins, I don't really focus on statins, and really don't even recommend statins for LDL levels, except for people that have what's called FH, familial or genetic hypercholesterolemia. And these are people, I've got some significant patients in that space. LDL, bad cholesterol levels, 300, 400. I mean, just huge, 450, 500, huge problems. But even then, most of those people still don't have a problem until something else comes in, like smoking or obesity and prediabetes, aging prediabetes. Yes, there is a balance. Statins actually do something else besides managing LDL. They decrease inflammation. How do they do that? And we're talking specifically about that inflammation which burns and creates hot liquid plaque. For some reason, we know that. You just do the studies, you look at the clinical trials, and they do it. Even if somebody's LDL was low, for some reason, statins tend to decrease their risk for heart attack and stroke. Even if their LDL was high and it didn't drop on the statins, it still decreased their heart attack and stroke. How does it do that? By decreasing inflammation. So one of the key points is I don't recommend statins unless you have plaque. A second key point is this. It doesn't take high-dose statins. Lipitor, for example, the most common statin, I think does more damage than good overall population-wide, as do most statin prescriptions, because people just give them willy-nilly based on age alone or LDL level. I wouldn't give a statin unless somebody had a plaque. The other thing to think about with statins is that in addition to some of the other challenges they cause an increase in this problem that's driving all of this. They cause an increase in prediabetes and diabetes, all except for one statin. And that statin is called pitavastatin or Livalo. Brand name is Livalo. Up until recently, it was prohibitively expensive. It's getting much, much more affordable. And no matter how much of a statin hater you are, and I'm not saying you are, I'm saying at times over half of my patients that needed statins weren't on them because for some reason I attract a lot of statin haters. I understand it. I've been a statin hater in my, and still have mixed, balanced perspectives on it. No matter which way you look at it, there's a significant science, body of science and evidence about stabilizing cardiovascular inflammation and therefore heart attack and stroke with statins. So hope that helps in terms of providing the balance you're asking about.
So I wonder how statins do get rid of the inflammation and get rid of the plaque. It has to go somewhere. So your spleen, your kidney, your liver, your lymph nodes, your gallbladder, all those filters, is it important to take into consideration how those are, or any of those more important than others, before you start detoxifying and clearing things? Is there something that needs to be looked at first, basically? Is the filter right?
Well, to your point, and related to that, there's no questions that statins tend to stress the liver.
Okay.
No question about that. They stress a couple of other systems within our body as well. I don't know that it's an issue of, so yes, you clearly need to keep an eye on liver enzymes. You need to watch symptoms more than anything else, cramping, stuff like that, for anybody who takes a statin. I would look 2 or 3 times very skeptically at any high dose statin prescription, and especially at Lipitor and some of the older statins. Frankly, I use a low dose rosuvastatin, or what used to be Crestor, 5 milligrams or less almost always, and sometimes 2.5 milligrams once a week even, or Livalo, both of which are very low dose, very gentle types of statins. the painful ones, the ones that tend to cause a lot of liver damage, muscle damage. Again, I think they cause more damage than help.
Have you been aware, there's some waters, they say like Fiji water, have high silica, and they're thin enough to break the blood-brain barrier and get in there and help to detoxify. That a lot of the waters, like the water you're drinking right now, might have fluoride and chlorine in and no minerals, but when you have silica in, high silica, it makes the molecules small enough to break the blood-brain barrier and wash out some of the toxins. Are you familiar with that?
I'm not. I've got a friend who's done a good bit of study on waters and also study about alkalinity and acidity, and I just haven't gotten there yet. I'm not I don't know a whole lot. As you can tell, I'm just actually, go ahead.
The reason I ask is all the water washes away the inflammation, washes away the toxins, and I mean, most people that are dehydrated can't heal. Once they get hydrated enough, then they can heal. Yeah.
Well, one thing I would tell you, the vast majority of people are way underhydrated. That's my perspective. I think we got to start with getting people hydrated. And I almost don't, and I'm less concerned about which type, even if they use tap water, which has got a lot of the bad stuff that everybody hates, I'd rather see them do that than continue to walk around so as dehydrated as they are.
Or replace it with Coca-Cola or whatever, sweet tea. Right?
Now, Brian, I just realized I am late for my next meeting.
Well, then let's wrap it up. Can you just give me your website information to the camera, and then we'll just say goodbye. Thank you so much for all this incredible information.
Well, thank you for your interest. The website, that we have 2 domains now, prevmedheartrisk.com, prevmedheartrisk.com, and PrevMed Health. So PrevMed is short for preventive medicine. So as I mentioned, we're undergoing a massive restructuring of our website. Right now, you'll get it under prevmedheartrisk.com, and soon you'll get it under prevmedhealth.com.
Well, fantastic. Thank you so much, Dr. Brewer, and I hope you have a really beautiful day, and thank you for all the wonderful information you gave us. Thank you.
Thank you. I appreciate your interest, Brian. Have a good day.
Good.